Summit brought to you by BlackDoctor, and we are excited to continue to power the future of our health. BlackDoctor, where culture meets care. So, about to turn things over to Yvonne Bryant, and she is going to head up our amazing fireside chat for the day. Everyone settle in because this is a conversation you do not want to miss. Thank you.
It's not on. Hello. Oh, awesome. Good afternoon. Oh man, everybody's half eating, half sleeping. Good afternoon. Thank you. Can I ask you to sit for a moment and close your eyes? Okay. So
Excuse me, how much longer will the wait be? I've been here since 9 and it's already 11. I don't think you understand. I have sickle cell and my arms and legs are hurting so bad. I need to get in there. I really can't wait any longer.
Yes, sir, I understand. We have to go based on priority and severity. We'll see you as soon as possible.
My case is severe. I've been waiting for more than 2 hours. This is ridiculous. I mean, I hate it here. They keep saying they're trying to get me in, but it's been hours. And this pain is next level. I can't move. I can't think. I can't wait any longer. It's been going on for days now, and I'm at my max, man. I really don't know how much longer I can take this.
Kenneth, we're ready for you now.
Finally, at 12:30. Ah! It feels like knives, like 1,000 knives stabbing my insides. I need relief, like now. Okay, just try to breathe, Kenneth. You've been through this before.
Hi, Kenneth. So the nurses tell me you think you're having a sickle cell crisis?
Yes. Do you know what that means? I've been in pain for days now. And the amount of pain I've been having, I really need some help. I'm at a 15 out of 10. I really can't take this anymore. Please help me, please.
Wow, okay, that's quite high. That would require some serious pain meds. Are you sure that's your pain level?
Yes, I'm sure. Doctor, please try to understand and listen to me. This isn't about pain meds. I'm having a pain crisis.
Let's get you started. Hold tight.
Why don't you believe me? Why don't you believe me? Why don't you believe me? Why don't you believe me?
In one study, approximately 2/3 of sickle cell disease patients who needed urgent care reported delaying going to the emergency department, or ED, because of stigma or other negative experiences. In another study, nearly 50% of patients reported ED providers did not believe their symptoms and they were treated like a drug seeker. This is Kenneth's story, age 27, living with sickle cell disease, a powerful example of the struggles faced by thousands of SCD patients just like him. Shift from acute crisis to proactive long-term care. Aim to reduce SCD morbidity and earlier mortality while improving health-related quality of life with a comprehensive, proactive approach. Preserve red blood cell health. Prevent VOCs and fatigue. Protect organ health.
Thank you for listening. That experience that Kenneth has is very common for people living with sickle cell disease who frequently are going to emergency departments seeking care. The care is being delayed. The lack of understanding of what sickle cell is and that experience is really detrimental to the health of these individuals, and the need to address that health in disparities and to change access for these patients is very crucial. So my name is Yvonne Bryan. I am the head of commercial at Novo Nordisk. And it's an honor to be in this room around so many prestigious leaders in healthcare and to really listen to all the panels. And I have my esteemed panelists here joining me as well. Dr. Ife Usunku and Dr. Shante Brown. I would like you to introduce yourself, tell them a little bit about who you are and your dedication and why you've spent your career focusing on sickle cell disease.
My name is Ife Osungwo. I am a pediatric hematologist who, because of the lack of adult care providers, transitioned my practice to take care of sickle cell disease from cradle to grave. I'm originally from Nigeria. My mother was a sickle cell nurse in the 70s. So I grew up going to public health events like this, talking about sickle cell disease in Nigeria, penicillin prophylaxis. It's not witchcraft, it's not voodoo, it's genetic. In medical school, I had a 2-year-old baby thrown in my arms by the mother who said, "Please, doctor, save my child." And the baby died of a sickle cell spleen sequestration crisis. Throughout my 6 years of medical school, I was very close to a family who had 8 boys, 6 with sickle cell disease. And throughout the 6 years, they lost 1 child every year. The oldest died the year I graduated. He had finished architecture school, couldn't work. He had multiple comorbidities. So my dedication to sickle cell disease came not just from being a smart doctor who wants to do well. It came from a long-term, deep personal experience from my community, friends, and I happened to marry into a family where there are 2 sickle cell individuals, and they had already lost 1 nephew who jumped out the window from the 3rd-story building and killed himself because of the pain. So this is a passion. It's not just a career, and I've been doing this for almost 40 years. Unfortunately, the story has not changed in the past 40 years. And that's why we're here today. This needs to be more than an academic exercise. That video, I've heard it so many times. That was my patient. But every time I hear it, I know that the work is not over. And this is not just a dialogue to just kind of, share data. This is personal, y'all. This is our people. These are our kids.
It is very deeply emotional, and I agree. I've heard it several times, and every time I hear it, I get upset and enraged all over again. Dr. Brown, can you tell us, you are the co-chair. I mean, she serves on a lot of boards, ladies and gentlemen. I mean, the list is eminent. This lady is a superstar. But you're co-chair of the Legislative and Regulatory Affairs Committee for the National Pharmaceutical Association. And you spend a lot of time using your voice to advocate. So can you talk about your advocacy in sickle cell and how you got into that?
Yes. So for me, it's definitely a passion, and I share in Dr. Osuko's, I share in your frustration, your passion, and just this outcry of rage that we have. I lost a really dear friend of mine from college. We just became like brother and sister. And he had a daughter and he has a wife, and he called me one day and he was like, "I'm having a sickle cell crisis and I am not going to the ED this time." And he refused to go because he knew, what comes with that. The video that just played, it's a very common theme. Not only have I witnessed it from obviously a close friend, but also in patient care. So he actually succumbed. He passed away. He didn't go. He was tired and he just didn't want to deal with it anymore. So with this, I my background, sorry, it's a little bit of, I do oncology. So in oncology, I treat sickle cell patients. This is something that's very common. And one of the things that I wanted to do was make sure that, again, we have access to care. So a lot of our patients don't have care that transitions from pediatric to adulthood. We don't have the training for our physicians to be able to take care of these patients because they're going to age. It's a chronic disease. So I do a lot of work in the Charlotte area nationally, treating patients, going into rural areas, working on the reservations. So I started there in New Mexico. So ensuring that all patients get access to the care, and also educating our nurses, working with the National Dental Association, working with our dentists, our dental residents. So I do a lot of education. That's really important, and working with all of our organizations cross-functionally is very important. So that's how I advocate. That's how I use my voice on panels like this. So I'm very honored to be here.
Thank you. Great to have you. How many of you have heard of sickle cell disease before and know what it is? Raise your hand. Good number, which is awesome. Sickle cell is considered a rare disease, though. And it's surprising because it feels like many of us know what it is, and it impacts about 115,000 people in the United States, but it is a global condition. And about 60% of those patients are African American or of minority descent. So it is our people who are highly impacted because it is genetic. But let's go a little bit deeper. Dr. Osuko, could you tell us a little bit around what is the clinical setting for sickle cell disease, and what are patients experiencing daily?
I think Yvonne mentioned that it's a genetic disease, and it came about as an evolutionary response to protecting you against malaria. So it's not purely a Black disease. It's a disease that protects people who live in endemic malaria areas. So all the way across Southeast Asia, Brazil, Middle Africa, but people move around willingly or unwillingly. And hence we have sickle cell disease in every single country in the world, about 8 million people. So what happens in sickle cell disease? You are born with red blood cells that are not normal in the way they are quantified, so the number and also the quality of those red blood cells. And because of that, three things happen. The cells stick together, they clump, and they block the blood flow. The cells break apart. They release toxins into the blood that cause damage to your blood vessels, a diffuse vasculopathy, and causes chronic inflammation. And then this chronic inflammation causes progressive organ damage as a mixture of inflammation and ischemia. So when you heard Kenneth screaming about being in pain and the pain being a 10/15, imagine you have a tourniquet tied on your arm and somebody forgot it. And after a while, you go numb and then you begin to hurt. And when the tourniquet comes off, you hurt even more. So ischemic pain is one of the worst kind of pain. They describe it as worse than a root canal, worse than labor, worse than a fracture. You've had people who've fallen down the stairs, broke their arm, and their sickle cell pain crisis is worse than a broken arm. They died 20 to 30 years before everybody else. It's an accelerated aging disease. So I got 24-year-olds who I'm afraid they may not make it to 30. 30-year-olds who won't make it to 40. Pregnancy is a huge risk factor. We think about cardiovascular disease in 50, 60-year-olds, they get it when they're 18, 20, and 30 years of age. So everything is worse, and you can still get all the medical problems that everybody else can get at the same time. So think about that, and think about the mental health burden, the quality of life burden. They can't graduate from school. They can't get a job and keep a job because they get sick a lot unpredictably. And they're stigmatized just because they need a lot of health care. And nobody understands it. And it's universal, not just Caucasian providers, but Black providers as well.
Thank you. Dr. Brown, just tapping into what we just heard around the clinical experience, but from a policy perspective, how does that impact the systemic challenges, or how does this impact the system that's set up to support these patients? And what does that look like from a policy view?
Thank you so much for that question. When we think about this perspective from a policy, we think about the big, beautiful bill, and we think about its impact on moving the allocation of funds heavily to the state. So about 50 to 60% of patients who live with sickle cell disease are on Medicaid or Medicare. So it's heavily state regulated. So what does that mean? If there's not anyone there to be educated on this disease, how do they know where to allocate these funds and who needs the funds. And the funds go far beyond the reach of just the actual care, right? To access to treatment, but it also goes further into the social toxicities or the financial toxicities. So the social determinants of health. So these patients need the rides. They need, they need to be taken to the care. If we already are at a limited resource from a clinician standpoint, how do they get there to this treatment? How do they get to the facilities that have the treatment? So are the funds going to be allocated to our academic and research institutions in every state? What about the states who don't have those? So really making sure that, our members are serving on these city council boards, because in Charlotte, I serve on the city council and I heavily allocate and push for the allocation for sickle cell disease, but also other issues too. So you need to be able to have clinicians, I would say. We also can be a strong voice for policy, and that's how I choose to use my voice. So really thinking about how all of us can do this together and work with our grassroots organizations, work with many other organizations to ensure that we are, advocating and going to Hill Days as well. So I do a lot of that, and that's how I use my voice.
It's great. I think we've recognized that, just as we've heard, not only with this condition, but many others, that there is a gap between what's happening in the healthcare system, where we've turned into being very reactive in the way that we provide care to patients, right? And not that all physicians are necessarily trying to do that. It may be the nature of what they're faced with, but there's obviously this gap. In order to break that cycle, we're looking at how do we, not only as an organization, Novo Nordisk, but many companies, how do you use advocacy to address those gaps?
I think the first thing is to understand the data and what the data means to the individual. Sickle cell disease is a chronic disease. It's not just a pain disease. And if we focus only on when they have these acute pain episodes, it's like saying that you have diabetes and I will only take care of you when your sugar level is over 500. It's a chronic, progressive, life-shortening disease, and it requires holistic, comprehensive care that is multi-sectorial, not just medical. It requires social determinant aspects. It requires financial, economic, work, school, education. All of these need to come together. It needs to be resourced like a chronic disease so that you can live well and then go to work, live well and then go to school. And I think that's the piece that, as a company, we can't do this by ourselves. We need to work with everyone across the different sectors to really articulate the cost of doing nothing and keeping the status quo is way more expensive to the individual, to the company, to society, to schools, and to the government. We need to do better. When you manage diabetes, you don't end up with an amputation and blindness. When you manage sickle cell disease, you don't end up with early death. You don't end up with blindness and pulmonary hypertension and leg ulcers and avascular necrosis. And so we need to think about this as we do other chronic diseases, and let's manage it and resource it accordingly, collectively as a community.
Ron, any thoughts on closing that gap?
Yes, I everything that Dr. Osuko said is 100% accurate. And just to tie into, as she stated, it is a chronic disease. And I think about my patients who come in and we talk about, one of my patients would say, so I thought I had this down pat. I thought I had this disease managed, but I've started to age. And, I can't go, maybe when I was in my 20s, I could go have a drink and not have to hydrate as much, but now I can't do that. I can't go and exercise as far as I used to be able to. So it's a whole body system. It's entire. So with that in mind, us making sure we educate the entire healthcare system. I also talk about when I work with my dental residents, a patient has sickle cell crisis, they did an x-ray, he had infarcts, he had root canals. So it is an entire whole, it's a collective, it's from head to toe. Everyone has to be involved and educated. It isn't just a singular approach to just a physician, just a pharmacist. It starts every single where. We have to educate everyone.
It's also genetic. And so mama has sickle cell. That means all her babies got her trait. And now we're telling our teenagers that before you fall in love, you need to make a conscious decision to pick your partner who doesn't have the trait. Don't wait until, you're planning the wedding and then you realize, oh crap, we're going to have a sickle cell child. That has led to so much agony and frustration. right? And so it really is important that people understand beyond just, oh, they have pain. It's something that we can make conscious choices and decide. And if you do have a sickle cell child, engage in proactive treatment. That's the best way to manage the condition going forward.
So I just wanted to tap into something you're talking about, and you spoke earlier about starting this career with your journey with babies. And now we see that there has been some progress, and people living with sickle cell are starting to live a little bit longer than before. Anyone as a child with a chronic condition tends to be wrapped around in a lot of love and support from a pediatric facility, right? You coming in, the nurses are loving you, they're helping the caregivers. It's a love fest,
Yes,
right? Because the access is slightly different. But then as we're seeing people transition into adults, we know there's this cliff, like you just mentioned. Now they're going to get married. Now they're into relationships. What are the risks at that transition age for many patients, and what can be done to support them?
So I was shocked when I started graduating my young adults out of pediatrics. There's a 3 times higher chance that they're going to die within 5 years of leaving me. And there's a 2 times higher chance that they're going to have multiple admissions to the hospital once they leave pediatrics. Why is that? As you get older, the disease gets worse, and the adult healthcare system wasn't used to seeing adults living with sickle cell disease. So there was no plan. And so we have to figure out a way to organize the healthcare system in a way that would support an aging sickle cell population. Its knowledge, its collaboration is multidisciplinary. The dentist, the OBGYN, now we're thinking about menopause. And we don't know what that looks like in sickle cell disease because nobody's ever studied it. So every specialty in adult care, you will see sickle cell. Start getting ready. If you haven't seen them already, my oldest patient is 89 years old. There was a 100-year-old person who died in Nigeria. You know, they're living longer, but they're suffering so much because of an unprepared health system.
Thank you. And Dr. Brown, what are advocacy groups doing to push for systemic change, especially when we look at vulnerable populations?
I think the biggest thing is education. And I'll say this again, education
Yep.
for the patient, because they're aging with the disease. So obviously their body looks different and feels different, but also education for our students. If we can start this earlier, a lot of my students get the benefit of coming to me because I'm educated on it. I treat sickle cell patients. But if we do not start this earlier, we don't have them prepared to be able to, again, to treat this, because we're seeing this, right? But Dr. Osuko just said that the oldest patient is 89. So we have to start with education. We need our organizations to help us and supply this funding, this pipeline for our nurses, our pharmacists, our physicians, our dentists. Everyone needs to have the knowledge to be able to treat, and treat in an ethical way, right?
Yes.
To show empathy, to not assume, right? So it's great if this model works. If we continue the work, that's what we're doing now. Is education is a big part of it. That's actually one thing I'm working on now, is educating our local pharmacists, giving them a checklist of things to go over, hydration, making sure that they have access to a local sickle cell provider. Even if it is just a pharmacist. I travel all through North Carolina. I'll drive 2 hours away to go see a patient. So it can be done, but it takes more of us educating the next generation and educating those that are working now.
Absolutely.
I just want to ask you too. So you've tapped into a couple of different areas, dentists, pharmacists. As we look at cross-functional stakeholder collaborations and really trying to drive change and develop comprehensive solutions, is there anyone else that you think needs to be a part of the dialogue?
Policymakers, payers, industry. I think people make decisions about sickle cell disease without understanding the true nature of sickle cell disease. So everybody, as they would say in North Carolina, right? Everybody needs to know. Everybody. I will talk to anyone about sickle cell disease all day, every day, because if you understand it and you show them corollaries, diabetes, nobody would ever think of diabetes as a acute diabetic ketoacidosis disease. No, it's chronic. Sickle cell should be treated the same way, and resourced and policies developed to establish long-term treatment plans for all who live with sickle cell disease. I'm not talking about gene therapy. I'm talking about basic care. If everybody gets basic care, we'll be in a much better place.
So true. And just to round it off, that was excellent. But like you said, if we start with getting basic care, and because this is a gene disease, it's a genetic disease, if you put resources into certain populations, certain genes, you may unlock answers to other disease states.
Absolutely. Right? What she
So,
said. Yes.
Just think about that. If you put the money towards the things that, okay, they may not deem that this is the most, the population isn't the largest, but it may unlock codes within our genetics to help other disease states and also come up with cures and prevention. So
very true.
maybe that's how we can spin it to get our policyholders and everybody.
I mean, it's a single
involved.
gene. It's a single gene disease, and the whole science around gene therapy has learned a ton from the science of sickle cell disease. So I think we deserve a little bit more attention because we're helping the people with the science, right?
We are. It's very true. So I want to say, you know, it's inspiring while listening to the challenges, right? Because there are many, but it also presents us with an opportunity, right? There are many caregivers, and they affectionately are known as warriors in this community who are really fighting to use their collective power and their commitment to changing what's happening in terms of their health, the inequities and the disparities, but really wanting to live. So we have an opportunity to do that. Novo Nordisk, we've been working diligently to support and to advocate and partner on behalf of this patient community. And you talked about, Dr. Brown, education and awareness. So I do want to show a quick video that talks about an educational initiative we're doing to inspire hope, to raise disease awareness, and then to tell the stories of people living with sickle cell, because there is power in voice. Absolutely. And there's power in sharing that experience, because the heart and the mind go together. And we need that to be a part of how we continue to make healthcare decisions moving forward.
I turned 69 this year. When I was first diagnosed, they really didn't give my parents much hope that I would even live to be 20. I actually was waiting to die. And so when I didn't die by 32, I was like, okay, I'm going to tear it up.
Let's talk about sickle cell disease. But before we get there, we have to start at the beginning.
I was about to say, what would you like to know first, really? This has been a lifetime of experiences since a child, in and out of hospitals, you know, near-death experiences, the whole thing.
It just means more relatable stories that get to come.
Everyone who gets the opportunity to experience this, to see the beautiful imagery of these individuals, that they feel the power of people living with sickle cell disease.
When I said challenge, it's times where you're not normal, when the world around you is normal, in a sense. So it's more on the side of living outside the box while everybody lives inside.
Thank you. We are incredibly proud to do the work. I think we all here, many of us in this room, we're trying to do good work in advanced healthcare, and it's a beautiful thing. So 30 minutes goes by faster than you think. You say your name and then 30 minutes is up. I don't know if we have time, if there's any one or two questions to be answered.
One.
Okay, not two, but one. We have one. Thank you.
All right, on our way. Okay.
I don't have a question. I just wanted to share a story. A year and a half ago, I lost one of my closest friends, and she had the sickle cell trait. And she knew that she had the sickle cell trait. She would always talk about it when we were in college. You know, I have the sickle cell trait. But she was never educated around what that could mean, right? And so looking back now, about a year and a half ago, she started going into menopause, 55 years old, started menopause. Obviously, that came with the hot flashes and the night sweats. She ended up getting really bad back pain and going to the hospital, where they found a massive tumor on her kidney. And this was in a city not with the great teaching hospital, anything like that, but she went 2 hours away to a teaching hospital. They still could not identify what was going on. And it was renal cell carcinoma as a result of overheating while having the sickle cell trait. And I remember reading every paper imaginable because I was trying to find a clinical trial. We found one at MD Anderson, and I said, okay, if you are, because I was doing these phone calls myself, I'm in pharma. So I said, if you can get comfortable enough, I will fly you and your husband so that you get there. And unfortunately, she never left the hospital after that. So I share that because that is the unknown. There's probably more understood by patients that have sickle cell because there's education. This is what you can expect. But certainly, even just having the trait, not knowing what to expect. So, and honestly, I don't think her physicians actually identified that it was the overheating that she was experiencing through menopause. We did our own research because she was in pharma too. So we were both reading through the papers, and that was our hypothesis, and shared it with the doctor later that said, yeah, that probably was it.
I am so sorry for your loss. I really am. And that's, it is a rare cancer, but it's classic for sickle cell trait. And it's pretty lethal. So I sincerely, I really empathize with the family. And you're right, the knowledge, the awareness needs to go beyond just the disease, but also the risk factors that people who have trait also suffer. Thank you for sharing that.
Thank you all so much. That was amazing. That was powerful. Thank you. Everybody, right? Everybody needs to get our information together. Yes, we want it official. We want it official. That was amazing. There's a lot of work we have to do, right? We have a lot of information we have to share. There's a lot that the medical community has to pull together. And just, I think the main thing I took away was the empathy. Also, having empathy, being able to recognize what it is that people are experiencing and coming at it with an open heart. So we're going to move over to the next part of our program. I'm going to welcome my colleague up, Mr. Will Blount.
Wow, wasn't that an amazing panel? Let's give them another round of applause. Well, I'd like to take this time to recognize a great business partner for BlackDoctor, and I would say a great friend as well. It's truly an honor to stand before you and recognize someone who not only excels in her field, shows up with purpose and passion, and with heart. It's Charity Williams. Wait. At UCB, Charity has made a powerful impact in advancing dermatological care, helping to ensure that innovation reaches the communities who need it most. But what makes her a true rising star isn't just her professional excellence, it's how she leads, how she builds, and how she shows up for others. Charity has been more than a partner to BlackDoctor. She has been a true friend, someone who understands our mission, believes in our work, and consistently leans in to help us move it forward. In this space where representation, advocacy, and trust matter deeply, Charity brings all three. And she does it with grace and with authenticity. So today is my privilege to celebrate her as a leader on the rise, a trusted collaborator, and a true and genuine friend. So please join me in congratulating Ms. Charity Williams, our inaugural Rising Star recipient.
Oh, okay. Those were really nice words. I did pay for that, by the way. No, thank you so much. I really am. I feel like I've got back to people. I'm really humbled and honored to just be here and be awarded like this, recognized like this by the community. I think being recognized by your peers is the highest honor. And so I really appreciate that. The few things I will say very, very quickly, I know my timekeeper is right here in the front row, girl. I see you. I will be very brief, but I just want to say a few things. I don't take the responsibility of this lightly. I know, as Rhonda said yesterday, for those who were in the room last night, what it's like to be the only in the room and have to advocate for your community and how important that is, and to make a way for other people to not be the only in the future. And so I recognize I stand on the shoulders of so many giants. Rhonda Peoples, one of them, all of the Hall of Fame recipients last night, the people being awarded tonight and have been awarded in years past. I'm so grateful to just be recognized, even in the same room with everybody. And my team is here, Logan, Tiffany, Alicia. I'm so grateful to do this work with people that I really, truly love, and have a leader, Brittany, who supports kind of our wildest dreams, truly. If only you knew. But I'm just so grateful for that. And most importantly, my parents are here. And I said to Logan earlier, actually, at our table, I said, they were the ones who received the report cards and like the calls from teachers when I talked too much in class. Nothing's changed, but I do hope that they taught me something meaningful to say. And so for that, I am grateful. And it's really because of them and because of the shoulders they stood on is why I'm here. So thank you all.
Wasn't that great? Yeah, let's give her another round of applause. So, how many of you love skin? Yeah, you just love skin and derm and all of that good stuff. Well, stay tuned because that's what we're going to talk about. I want to bring my brother from another mother to the stage, Dr. Adam Friedman, chair of dermatology here at GW. And he's going to talk about HS. You guys, he'll tell you what that stands for because that's really big and I don't want to mispronounce it.
Thank you. That was the most original intro I've ever received, and I'm definitely going to own and hold on to that as long as possible. Good afternoon, everyone. Thank you so much for having me here. Though this is also the shortest commute I've ever had, literally from down the street. As you heard, I am professor and chair of dermatology here at GW, but more relevant to our discussion today, I am co-director of the hidradenitis suppurativa program, also known as HS. I do also want to throw right back at Dr. Ashanti Carter for inviting me, and of course, BlackDoctor as well for hosting me, and of course, having this incredible program. So before we bring up our incredible panelists, who are really going to shed some significant light on the experience and what we're trying to do to improve outcomes for HS, I think we should level set a little bit and talk about what this disease is. So first and foremost, HS is not another more than skin deep. It's in a category unto itself. Yes, psoriasis, eczema, these are absolutely chronic inflammatory skin diseases just like HS. But HS has such a unique, destructive biology that translates into recurring nodules and boils that, when not treated, turn into forming tunnels under the skin, scars that could prevent someone from even lifting their arm to brush their hair. It is pain like no other, pain that is so disabling that it can completely disrupt the fabric of one's life. HS is not cosmetic, it is not mild, it is life-altering. Now, follow me in my bakery to create the layer cake that is HS. So we talked about what this disease looks like. Let's talk about this from the framework of a systemic disease. HS is not just a skin condition. It is associated with possibly every medical problem you can imagine, high blood pressure, diabetes, arthritis, to even mental health disorders. We need to reframe this condition. This is not just simply a skin condition, but rather is the skin findings of a systemic condition. Next layer, delays in diagnosis. On average, from the time of onset of disease to the time the diagnosis is made, we're talking about 7 to 10 years. That is 7 to 10 years where those boils turn into scars. That is 7 to 10 years of someone jumping around to different physician offices, being misdiagnosed, possibly dismissed, possibly given countless treatments that do nothing, possibly surgeries that make the matter worse. So again, we need to do better because we owe it to our patients to not miss what we call the window of opportunity. It is that period of time where we can intervene to stop all those horrible things I just mentioned, to stop the tunnels, to stop the scarring and deformity that really we can only manage with surgery. Let's go to the frosting on top, okay? Let's talk about disparities in care. Let's talk about the psychosocial impact. So I mentioned what this disease looks like. Now let's throw in where it's typically located. Chest, groin, the buttocks. So imagine a condition where whenever it feels like it, boils can pop up on those very sensitive areas and how that could really perpetuate shame, isolation, and impact every facet of one's personal development and life. Now let's add on disparities in care. We know fully well, there's plenty of evidence to support that various marginalized populations, various patient populations, especially when we think about Black patients, they are even have more of an issue with respect to access to care, accessing physicians who even know how to recognize this condition and treat it appropriately. So again, a lot of missed opportunities. So at the end of the day, this panel that we're about to have, which I cannot wait to start, is not about treatment algorithms. It is about how do we see patients better, how do we listen better, and how do we address this efficiently. It is about really redefining this condition as a systemic disease. That yes, if we do not treat the skin, we are also not treating the whole, which could lead to countless other medical problems. So with that, let's get it on. Can we please have the panelists come up? And I'd love for them to introduce themselves. There. Dr. Carter tells me exactly what to do. I'm just going to stand like this, and she'll move me. Get nice and cozy up there. Mm-hmm. All right, well, why don't we kick it off with some intros?
Hi, how are you? I was so excited that you were moderating this panelist. So I am Tiffany Crawford. I am the U.S. head of HCP marketing at UCB.
Hello, everybody. Thank you to Dr. Ashanti for inviting us here. Appreciate it. BlackDoctor. My name is Jeremy Hingston. I am a photographer and audio engineer.
Hi, everyone. Again, I'm Charity Williams, and I lead patient marketing for HS at UCB.
Hey, everybody. Thank you so much for having me. I am Sydney Carter. I am a mother, wife, friend, and also a patient advocate living with HS.
All right, why don't we get started? Tiffany, I'll start with you. Can you talk to us a little about what is health equity in dermatology? As especially relates to, I mean, obviously I focus a lot on HS. I don't want to throw shade on psoriasis, as that's an extremely disabling condition as well, and so near and dear to your heart too. But we talk about it from the framework of those conditions, especially again when we think about Black patients, Hispanic patients, and what do we need to think about?
Yes. First off, it's important that we ensure that there's a pathway to access, but also a pathway to elevated care. So how do we do that? Number one, within the Black and Brown community, as you may know, dermatologists, clinicians, we don't go there. So the first thing is to educate these populations on the importance of dermatology. It's not just so that you look good. There is a reason to deep clinical care within dermatology. The second thing is to teach patients to advocate for themselves. And we have an amazing example here on this panel. And when I say advocate for yourselves. Yes, understanding the disease. And this is something I do not mean to disparage the clinicians in the audience, but one thing that I share within my family, just because there's the white coat doesn't mean that the clinician is right. Push back, ask the right questions. If they're speaking a language that you do not understand, ask the questions. So we have to teach that. And then lastly, at UCB, under the direction of Charity and her team, it's all about empowering, teaching, especially with HS, that this is not a condition to be ashamed of. This is not a condition that you caused. And even though that there's history, because there is mistrust, because these patients have gone to a plethora of clinicians that have told them that it was their fault, and that they did not do the necessary steps that has caused this disease. So teaching them to empower themselves so that they can get the appropriate, proper care.
I want to echo something you said. One, as a patient, be an advocate for yourself. But actually, question, by show of hands, who here is a physician in the room? So I think it is also inherent that we need to teach our residents or medical students that it's okay for patients to be advocates for themselves. That I think one of the reasons why maybe people shy away is that we tend to get defensive and that we feel like we're being challenged. And so I think in order to really truly meet someone where they are, we have to be fragile and open to accepting that feedback because we only know what we know. And I think we have to be okay with it. And that has to start from day one in training, or else this will perpetuate. I think that's a very, very important point. So shifting gears a little bit, and I'll call on Cindy and even Jeremy for this. We are so fortunate to have those who have experienced this firsthand to really give us the lived experience. Can you talk about some of the challenges you faced, Cindy, early in your journey with HS?
Yeah, for sure. So I think my journey started with HS around 11, 12 years old is when I started getting the boil-like abscesses in between my thighs. And, you know, I had played sports my whole life. I played sports since 3rd grade through high school. And so I thought maybe because I played volleyball, like it was maybe for my spandex, or I did a lot of self-blame because I had like sexual trauma from child issues, and thought maybe that was what was going on. Like obviously I wasn't sexually active at my own, like on my own accord. And so I, from a very early age, blamed why I was getting HS symptoms on myself, which made me like not want to talk to my parents about it, not want to talk to my mom about it. She at the time was a medical assistant even. So like, even though I knew maybe she could help me, there was not that correlation of like, this is okay to talk to her about, until it started impacting the way like I physically could walk. And she was like, well, what's going on? And so then at that point, like I would let her know, and she just didn't know what I was dealing with. And so that was really disheartening. There's like strikes, right, that happen in your adolescence age of like, okay, like if my mom doesn't know what's going on, like nobody's gonna know. Then when it got so bad to where it was so inflamed, I needed to go to the emergency room, and like you go to the emergency room, your mom doesn't know what it is, and the doctor's like, well, how do you, I don't know what this is either. Let's just drain it, pack it, send you on your way. And so that was my journey with HS for a long time until I was in high school. I happened to be doing a internship through a dermatologist's office, and that's when I put 2 and 2 together, that dermatology means skin and they take care of skin, and that I left that internship making my own appointment at the same dermatologist's office. And I went back a few weeks later to my appointment. She said, hey, you have HS. She gave me some antiseptic wash to go on about my way. And at that time of diagnosis, there was no treatment options available. So even though I left with an answer and I had something to go home and Google, I still very much so felt like defeated, and that there was not a lot of options for me living with a chronic disease at 17.
Thank you so much, Sharon. I think the word defeated, what I think a lot of patients feel, and I'm hoping we're changing that in modern era, but for too long that was often the case. I think when you throw a condition in terms of what it looks like and where it occurs, assumptions are made. And I think that's one of the struggles, that it looks like an infection, even though it's not, but that's the path of least resistance. So, oh, it's an infection, let's cut open and drain it, go about your merry way, you're not my problem anymore. A lot of patients feel that way. Jeremy, what about you?
My experience was a little bit different than Sydney's. Mine came on when I was about 32 years old. And it started as just a little bump, like most people starts, just one little bump. You think it's an ingrown hair or something like that, a pimple. I didn't really think anything of it. I just thought, okay, ingrown hair. I'm a guy. I'm like, whatever. I'll deal with it later, which is terrible when you think about it. But it wasn't until a few years later, and I was diagnosed by a nurse by accident. I went to see my doctor about asthma refills, and I had trouble sitting down because I have a big bump on my waist. And she was like, "What's going on?" I said, "Oh, I just have this big bump." And I showed her, and she's like, "Oh, that looks like HS." Okay, thanks. Can I get my asthma medicine? And then I left. Fast forward a couple of years, and now it's appearing in both armpits, and I can't take my shirt off or put my shirt on, and I'm on the couch for a couple of weeks. That's when I started to get seen by a dermatologist. And in hindsight, now that's way too late, because when these bumps start happening, if you don't get seen, they develop tracks. If you're taking medicine to help control this, those might not appear. But if you don't get seen and you develop tracks, now you have surgery. There's not another, medicines aren't fixing the tracks. So I just let it go. And it got really bad. I was on, different biologics, trying to navigate it. And eventually, fast forward a few more years, I was ended up being bedridden for about 9 months. And a lot of stigma is about weight, smoking, things like this. I know so many skinny people that have HS. It's not weight. And I've had doctors even tell me, oh, you got to lose some weight. Okay, so when I was bedridden, I went from weighing 250 pounds down to 165 pounds. And I was at my worst, and it didn't stop. It's not weight. I was skinny. I can't even look at myself like that. So there's a lot of stigmas, and advocating for yourself is one thing that I'm very big about. I just had a doctor's appointment not too long ago, a week ago. And I asked my doctor, what new medicines are coming out? I know there's about 10 or so, maybe more in the pipeline. Do you know anything about what's coming out? Because what I'm on right now is not really managing. Oh, I'm not really sure what's all coming out. I haven't had the chance to look. And I'm getting that kind of response from a lot of people. It's like, how are we supposed to move forward if your doctors don't have the time to research what's destroying you? So it's been difficult.
I wish we had 3 hours to kind of second all the things you said, because there's so many important teaching points. You bring up about misperceptions and weight. And I think that there's so many pieces. One is I teach all of my residents. You don't talk about weight in the first visit, first of all. But two, there is this blame piece to it, right? And I think that goes to the kind of infectious appearance of like, well, this is an infectious disease. It's you did something wrong, which adds to that burden of disease, which absolutely, you're right. You could be stick thin and still have rip-roaring disease. I think that's a very important point. And, I'm sorry also that you had that experience in the healthcare system where someone's response really said to you, I don't care enough about this to know. That's really what they say. It's like or someone saying like, oh, I'm going to send you to someone else because I don't know how to take care of it. It's also, it's a way of saying, well, I don't care enough to know. You're very fragile and open in a position. So I'm sorry that you experienced that.
I appreciate that, but I'm not sorry, because of that, I'm able to speak about it and educate more people not to do that. So I'm not sorry.
All right, I'm going to turn it over to the award-winning charity. I know you've worked with Sydney for some time, and I know you've heard many stories and interfaced with many incredible patients with HS. How have those experiences shaped your experience and your drive and what you do at UCB?
Yeah, no, thank you for the question. Sydney, we were talking when she came in. I was like, when did we start working together? And I think it was January of 2022, we realized. And I think what we uniquely did, and, when I started this work, I realized I don't know enough about this condition. One, we were still very much learning, but no matter how much knowledge that I was able to retain and learn and understand, I knew that no one would know it better, be able to teach it better, be able to talk about it better, represent it better than people living with it. And so that's kind of how this work started with Sydney, who kind of helped us create our campaign from the very beginning. I mean, for us marketers in the room, literally looking at like talking to an agency and saying that's not going to work, that doesn't work. And it was bringing people into the fold to tell their stories, to hear their stories, which I think is so critical. And we've built a great relationship since then. I've been so fortunate to watch her grow. I've worked with Jeremy since then, and they've been such an asset to us as an organization, transparently, because I think the only reason that we have been successful is because we've told the story, but not from us, but from them, and to their peers. So.
And along those lines, throwing back to Tiffany, from her vantage point, what do you think some of the biggest systemic, maybe informational gaps that we really need to address in partnership? I think that this is such a great representation of partnership. You can't do it on your own island. You got to do it together. How can we work together to address some of the gaps that you're seeing?
I think that is an important question, and to build on some of the things that we've said already, the education, that's a huge gap. You mentioned an important one of teaching future clinicians how to engage with these patients and engage in a way that's meaningful, but does not defeat them. I think the second thing that is a gap that Charity, you hit on in terms of the creation of the stories. We need more stories, not stories that are generated from marketing, but stories that are generated from real patients. And the reason why that is important is that those stories will trigger a couple of things in the patient that, hey, it's not me and I'm not alone. And the second thing is the caregivers. I struggle because I think about adolescents. I think about kids that are suffering with HS. And, in many Black and brown communities, if you get a boil in certain places, can you imagine that conversation with that parent? And so those adolescents become withdrawn and they keep the disease to themselves. And to your point, it worsens. So educating caregivers so that they know how to approach children or adolescents and the right discussions to have with them. I think those are the two major gaps that we have.
I agree. I think the greatest educational opportunities are cases or stories. And along those lines, not to take away your shine, Charity, but we do have a TV star in our midst. So I know you were part of the History campaign for HS, part of the commercial. I would love to hear what that experience was like for you, being someone who has had a journey where you've been bouncing around, uncomfortable to even bring it up, let alone not getting the right diagnosis. How did this complete 180 of being in prime time, being able to talk about this to a lot of people, a very large audience, but also recognizing that this opportunity even exists for some?
It's what dreams are made of. No, every single day I'm very grateful and I'm very fortunate to do what I do to advocate at the lengths that I do. I'm able to bring HS awareness. I mean, they had me on a Times Square billboard, like it was like bigger than life, excuse me. And it's completely changed my life and the way I view myself, the way I show up for myself, and the way I show up for my children and my family. Whoever had the idea earlier about the cookout cards, I'm like, let's just add a little box on there that says, do you also have HS, or have you gotten 2 or more boil-like abscesses in the last 6 months? Because so many people in the Black community are not talking about HS because it's correlated to maybe you have chronic boils, or maybe it's an STD, or maybe they think it's contagious, and there's a lot of shame rooted in the stigma of that. And so to be able to show up on social media the way I do, show my skin, be confident in myself, learning to grow confidence every single day, I'm showing the adolescents who are on social media inevitably that it's okay to have scars. It's okay to not have a perfect aesthetic body that society pushes onto us. And it's okay that even if you have HS, because one, we're making sure that if they don't know anything about HS, that they know that it's not their fault. And so being able to be a part of the Make History campaign and be, I mean, it's just not about me. So I try not to, I don't like to make it about me. It makes me really uncomfortable. But I love that God has been able to use me in this way and turn my pain into purpose and help other people know that they're not alone.
Jeremy, I love what you said about not being sorry, because each of these interactions and experience fuels your desire to advocate on behalf of yourself and others suffering. Could you maybe speak a little bit to that? Like, what was your aha moment in terms of really being an advocate for those who maybe don't have a voice? And in parallel, maybe how that then translates to partnering with those engaged, like you, others, to really make sure that voice is amplified.
Oh, it's been amazing partnering with UCB. Like, they have been so amazing, just spreading awareness and helping us, because we're only so big as individuals. You know, we only have so much money. They've got budget to do things, to put on things like this, you know? We can't do that. We can't go buy a billboard. We don't have that kind of money. We got to pay bills, you know? So that it's very important. Also about advocating, for me, when I was at my lowest point, I was bedridden for 9 months. I was 165 pounds. I had it in both armpits, my groin, my butt, my waist. I had to think how to reach for a glass of water the least painful way. 9 months of that, dark things go through your mind. And I honestly don't think I would be here if it wasn't for my wife, my caretaker, holding me up, because that was a dark time. And so when I was going through that time, I was on Facebook and looking at all the groups, and it was just despair. And when I came out of it, I said, you know what? I don't want anybody to feel like that. I travel all the time. I play guitar. I shoot, camera. I'm a photographer. I don't want anybody to feel like how I feel. So we decided to start Warrior Stories, and we travel the world and interview other HS warriors. But instead of just having them tell their story, we want to inspire people. We say, tell your story. How did it start? What are you using to treat it? And then we focus on, who are you? What inspires you? And then we'll video them doing their passions, whether they're cooking or playing basketball or singing. We want to inspire people. And that's really where Warrior Stories came from. We just did one in Japan not too long ago. We interviewed the leading dermatologist in Japan to get his ideas about HS, interviewed another warrior. So it's just all about spreading awareness. We just want to inspire people. And another thing that's crazy is a lot of people don't realize how many people have HS. You guys probably have never heard of it. And what's crazy is, on the low end, 80 million people in this country have it. 80 million. That's a lot. And if you look at, we've heard clinical trials being talked about too. If you look at not that I'm comparing, but like IBD or Crohn's disease, right? 7 million people affected, 1,500 clinical trials. HS on the low level, 80 million, less than 300 clinical trials. And this is a devastating disease. So it's all about inspiration, getting people to talk, getting people to realize that you're fine. A lot of us go through the same stuff, and we're here and we're still rocking it, and you can too. So that's what we're trying to do, is just get people to understand that and tell their story.
Something you said, which I think often is on the network and the family. I love that you gave your partner a shout out, and I think we often underestimate the impact of this disease. So when I see patients here, they're rarely by themselves. They're usually with a family member because of mobility issues, just even emotional support. And so I think we need to also acknowledge those that care for HS patients, but are really in the trenches too.
Sid's husband.
Yes.
Also, shout out. You're killing it.
So the next question is for both Tiffany and Charity. In thinking about what we've heard and initiatives that two incredible patients who are definitely not afraid to share their voices with the world, how is UCB going to measure success? Like, how are you going to really appreciate, is everything you're doing, which we are so thankful in every community, how are you going to measure success, and how is that going to direct what you do?
Thank you. That's a great question. I think the first thing that Charity and I both have to do is, and we've been along this journey, is educate the organization that measuring the success of the initiatives that her team comes out with is different. Typically within business, and the marketers that are here, they know it's about share, it's about revenue, and it's about the number of patients that you bring into the fold. But when you talk about initiatives that affect Black and brown individuals, the success looks a little different. especially some of the things that we've shared up here about lack of education and working to get individuals to advocate more for themselves. So what that looks like is how many patients can we drive into an office to advocate for themselves? How many more real stories can we create and partner with individuals like Jeremy and Sydney so that we are getting the education and making those connections in the market? And then lastly, I would say is how can we educate more clinicians so that they understand what they are seeing when the patient walks in the first time. And if they're not apt to treat the condition, that they have the wherewithal to refer to a dermatologist clinician that knows how to treat HS effectively. That's what success will look like for us at UCB.
Yeah, I agree with everything Tiffany said. I think the one thing that I also would like to add is we talk so often, and you mentioned this about return on investment, but there's an element that we should all be thinking about is the return on equity. How great is it that I can pick up the phone or text either one of these individuals and say, does this sound right? How is this working? And before I've invested thousands or millions of dollars into the market for something, right? And then it doesn't work. And I've got these people that I can call. So there's equity in some of these relationships that is not measurable quantifiably, right? I can't count that, but I know that there's value in that. I can't see where the dollars are saved, but I know that they are. And so I think that's one thing. How can we really train and help our organizations understand, like, not everything is a return on investment in the same way that we're used to thinking about it. It's really an equity play, and that's important because we have these deep relationships with general market for decades and decades and hundreds of years, and so we need to invest in the same way in populations and communities of color specifically. And so to me, like, it's the return on equity that I think is really critical, and I think the idea that anyone can look at one of our campaigns and say that got me to a doctor, or that enabled me to have a conversation, or I finally saw someone talking about HS. I never thought I would see that. Like, those are the things that I think bring us the value and know that we're doing the right things. And that is success for us.
And it's happening all the time.
And I wanted to
I was
piggyback
at
on
the
that.
airport and somebody's like, "Oh my God, I follow you! I saw you on the commercial!" And it's like, it's happening every single day, and it's happening in my comment section. It's happening in the DMs. It's happening in real life. It's happening in real time. So we appreciate you guys for your partnership.
If I could quickly piggyback on that and say it's already, the success is there. You can see it. Back when Sydney was one of the first advocates, there were no other people really doing that. Now there's a ton of people telling their stories. There's the sisterhood, there's the teens forums, there's the HS Brotherhood. The success is already shown. It's just getting bigger and bigger with all the help. It won't slow down. Can't stop, won't stop.
All right, we're going to wrap this up. Some rapid fire last questions. So first, Tiffany on the chopping block. One action a healthcare leader can take tomorrow to advance dermatology equity. You have 10 seconds. I'm just kidding.
No, that's hard for me. Listening to your patient.
I can't compete with that. I can. Charity. One misconception or misperception about HS, especially in patients with skin of color, that needs to be corrected yesterday.
I think someone said it earlier, pray, but also go to the doctor. Those two things are not mutually exclusive in our community.
And then for both Sydney and Jeremy, one word that captures what this initiative.
Empowerment. It's crazy. Something that made me feel powerless for so long has given me purpose and brought power back into my life. So I love empowerment.
I would go with inspiration because being a part of things like this and seeing people that actually care and working with industry people that actually care, it's inspiring to get out and talk more about it and invite other people and say, look, these people really care about us. Tell your story. So inspiring is what I would say.
Thank you I was a resident working at Einstein in the Bronx, I would never, ever have expected to have a panel with patients, industry, physicians talking about HS. It was one of the greatest challenges, as you know, for so many different reasons. So even in just 2 years, because I just graduated 2 years ago, clearly, in a very short while, I'll say, the landscape has changed so dramatically, and we owe it to everybody. We owe it to our incredible patient advocates. We owe it to our industry partners. We owe it to the physicians on the front lines, even before it was cool to be into HS. And I think everyone here has really gotten just a small taste, but an incredibly tasty taste of what it means to adequately and effectively talk about this disease, but also ensure that patients are being diagnosed in an appropriate and timely manner and getting on the right treatment. So thank you so much, everyone, for your attention. I don't know if we have time for Q&A. We have time for Q&A. Dr. Carter says so. Don't fight with her. We have 5 minutes for Q&A. Any questions from the audience? Yes, please.
So my question is actually for you, Jeremy, and also for Sydney. Looking at you guys today, you look like you're very comfortable. You don't look like you're in pain right now. But you mentioned, Jeremy, that you were looking for updated treatments, the new technology that was out there. Where are you guys today in your level of health, if you don't mind speaking on it? And where is the direction of treatment going today in HS? Are you finding what you need?
Ladies first.
I am coming out of my, childbearing era. So I just had like 3 kids in the last 5 years. It's fine. So I am, I am looking now for and excited for what's on the horizon when it comes to HS treatments, because I know postpartum can be really hard living with HS. I have like a flare on my butt cheeks right now and one on my thigh, and that's really hard with travel, but I would never miss anything to bring awareness, so it's all worth it at the end of the day. But definitely excited for what's on the horizon, and it's never good to have HS, but like it's a good time right now to have HS is what we say. So really grateful for where it's going.
Yeah, for me, I just had wide excision surgery on both my armpits in January. So and unfortunately, it was done an old school way, which isn't necessarily bad, but there's new, better practices that heal better. I hoped for it to be left open so he could take out a lot, and he closed it, which means he didn't take out very much. So literally 4 weeks after getting out of surgery, I have HS all around both surgical wounds. So my journey is I'm gonna have to get more surgery again, maybe next year, hopefully for CO2 laser and leave it open, take out my whole armpits, don't leave anything. But I've also been on just about every biologic, as well as infusions for rheumatology that would help HS. The current biologic that I'm on right now has been keeping things at bay, but I'm getting a side effect of folliculitis, and it has grown a lot, and it's all over. So I just saw what I was talking about, seeing my dermatologist last week, asking him if there's anything new, and he didn't really know. And so that's where I'm at. I'm hoping for whatever's coming out. I know there's a bunch, 10, 15 maybe drugs in the pipeline. So I'm looking forward to that, and then looking forward to CO2 laser and taking my armpits out again.
Hi, more or less a statement than a question. I just want to thank you. I have HS myself, and honestly, I have never acknowledged it really until this point because I was so ashamed of it. There's always one in the crowd.
You got a whole family.
Yes,
You got a whole family.
I received some barbaric treatment in my days, cutting, abscess, not even giving me anesthesia or anything to numb it. I've had doctors tell me to shut up and just take it. I've had some truly horrible instances with it, but I'm just happy to see that it's being acknowledged and being addressed. I just want to thank you. Thank you.
You're not alone, girl. You're not alone.
And I hope
so
you're
much for sharing
being
with us.
treated. I hope you're being treated and feeling okay. It's tough.
I may know a guy.
HS Connect approved, by the way. He is HS Connect approved.
Yeah, actually,
check out our resources on hsconnect.org.
I'm glad you brought that up. So HS Connect is a wonderful patient-run organization that has, in just a few years, become literally ubiquitous with advocacy, HS, and patient empowerment. So if you're not familiar and if you have HS, absolutely got to check it out, because who better to hear from than someone experiencing similar things to you?
And also, I want to throw in OSID as well. I love HS Connect. I work with them a lot, and they're all amazing. But also, Jasmine has founded OSID, Association of Hidradenitis Suppurativa and Inflammatory Diseases. Amazing resources.
Agreed. Questions? In the last 60 seconds, anyone? Going once, twice. Sold to the man with HS. Thank you, guys. Amazing. Thank you.
Can I give it back?
Yeah. No.
Awesome. Rob, thank you very much. I appreciate it. Oh, sorry. Yes. Yeah.
Wow.
I'm
Another good
speechless.
one.
I'm
Unstoppable.
yeah. I'm
It just keeps going.
yes.
It just keeps going.
Yes.
It keeps going. Well, I'll let you go first this time. What was impactful to you? What stood out to you?
You know what? I took some notes, but I'm not even going to read them just because with this one I got to say just a huge thank you to UCB. You know, because I'm listening to, you know, just these patient stories, and I'm just astounded at what people have to go through. You know what I mean? Like, people are dealing with this thing day in and day out, and usually silently. So they're silently suffering in pain, but for somebody to say, I see you, I want to help you, you know, let's build community together. That's incredible. You know, just to hear this young lady, you know, and talk about, you know, when she was so young, and I've got a daughter, you know, and then to think about her suffering in silence, not wanting to talk to her parents, man, that's heartbreaking to a parent. But, you know, to having an entity like UCB making it not necessarily cool, but, you know, making it okay to share your story is powerful. It's powerful. So you have power in your story. So thank you. Thank you. What did you think? What did
You
you
know,
think?
I had the same feeling. I had the same feeling about the stories. And being an executive editor, that's what I do. I tell stories all day. I find the stories.
Yes.
And even to see the woman over there stand up and say, okay, now I can
Yes.
finally talk about it.
Yes.
Now I have this, and I've
Man.
never spoken about it until now. That's why I want to tell the stories.
Mhm.
That's why I'm going to come and talk to you afterwards. I'm going to
Yep.
come and talk. Everybody has a story. You even shared a story about someone that your personal friend and their experience. So that's why we tell the stories, because it helps people feel seen. It makes them feel comfortable finally talking about it and saying, hey, I'm not alone. And now we can also tell people that are around us, like, hey, this is what I'm dealing with. Here's how you can help me through it. Or, hey, can you come with me to the doctor's office? This is what I've been dealing with. Can you listen in and field the questions for me in case I'm not hearing it because I'm out of it that day, or
Right.
it's just hard for me to hear. So it's the stories, man. It's the stories.
Yeah. That's why we do what we do at BlackDoctor. You know, there are so many stories out there that's not being told, but hey, we're gonna make sure that they are told. So we're going to keep telling those stories in the next and final panel of the afternoon. This panel is next up, Powering the Future of Our Healthcare Workforce. Please welcome our moderator. Come on up.
Thank you so much. Good afternoon, everyone. My name is Robert Rock. I was just checking. Is it morning? Is it afternoon? There's just so much love in the room. Time just, we don't know. But my name is Robert Rock. I am a family physician, so a primary care doctor, also very much a story collector, holder, passer honor. I am with the Social Mission Alliance. I have the distinct pleasure of having the best job in the Social Mission Alliance, which is director of the Health Justice Fellowship. So working with our next generation of leaders who are actually leading right now. And I'm also co-chair of our Advocacy Advisory Council. And this is a panel that's really near and dear to my heart because relative to all of the stories that have been shared in the room so far today, there are reasons that motivate us to do this work from whatever position we come to do it, whether it's patient advocates, industry leaders, care providers, care navigators, et cetera. I think in the health professional trajectory, as you are socialized to become a physician or any kind of healthcare worker, we're often made to forget the reasons that we come in here, the people whose love really guide us and direct us. And so there's a lot of work to do relative to supporting our pathway of health professionals to hold true to that why, to keep acting with love, and to be the champions that this healthcare system and the society needs. So without further ado, I'm gonna introduce our distinguished panel of incredible current leaders and future leaders, Caitlin, Peyton, and Queena. You can come up. Okay, great. All right, so I want to start with the first question being kind of a twofer because I know we have 35 minutes of time and I want to make sure we use it as best as we can. So can you each introduce yourselves and share a little bit about the journey in your health career to this point and what gives you the most hope and still leaves you concerned relative to this journey that many other people are on?
I guess I'll get started because I love efficiency. I'm Caitlin. I am a third-year emergency medicine doctor over at GW across the street. From this point, I actually started my educational journey in high school, went to a summer program, a pipeline program that showed me my love for science and actually led me to being a science teacher in Baltimore first. From there, kind of had a lot of experience with the students that showed me that they didn't understand a lot of health literacy. Being in Baltimore, there's a lot of asthma, there's a lot of allergies, there's not a lot of education on like sexual health. And that's what motivated me to go into medicine. Got to go back home to Florida, went to medical school, and there somehow that transitioned into me wanting to care for the most vulnerable and being an emergency medicine physician. I'm in my second to last year, so next year I'll be starting as the education chief for the program.
That's amazing.
Yeah. And the thing that gives me hope, honestly, is events like this where I see people who still are so passionate about advocating for the patients, about sharing these experiences. This is kind of what makes those long hours in the middle of the night in the emergency department worth it.
That's beautiful. And one concern? One concern?
I'm a little concerned with the shifting away from guiding the students, especially those from underrepresented backgrounds right now. There was a lot of kind of framework to support these students in the past, and we're seeing a lot of changes in medical education, which no longer is supporting them. So I worry there's not going to be a whole lot of doctors that look like me in the future.
Thank you. Peyton?
Well, hi, everybody. My name is Peyton Turner. I am a current senior at Emory University. I'm getting my bachelor's degree in human health and economics. And then next year, I'll be getting my master's in science and public health and data science with a concentration in environmental health. That's a mouthful, but so that's a bit about me. I came in to Emory as a neuroscience and behavioral biology major. I was pre-med. I was so confident I was going to be a doctor, everything like that. And then I took my first orgo class. Man, I think I got like a 48 on that first exam. I said, you know what? I don't think this route is for me, and that's okay. Luckily, I was taking an econ class at the same time and realized that I really loved econ, hence my major, and wanting to go that route. So that summer, I was working as a medical assistant actually in Philadelphia. That's where I'm from. I was working in an HIV/AIDS clinic, so I was working with underserved and uninsured populations, really focusing on sexual health, health literacy, and working with those patients made me realize how many gaps we have in our education system, especially when it comes to healthcare and things like HIV that have so much stigma around them. So that's definitely a passion project of mine. And now I'm interested in pursuing something in data science because I think everything we do in healthcare is informed by data. Understanding how to interpret it in a way that all audiences can understand it. So people that aren't in a technical field like science, but are just general public members, putting it that way and being able to use that data to make health outcomes better for everybody, that's going to be really important. And especially in environmental health, which is something I'm super interested in as well, environmental justice and environmental racism. So yeah, that's my pathway. And I guess one thing that I'm really hopeful for is the use of AI and data science in healthcare. I'm really impressed by how quickly we're evolving to use that technology for the better. But at the same time, I am a little bit concerned about bias and incompleteness in that data and how that can further reinforce the disparities that we're actively trying to fight against. So just using that meaningfully and reasonably with accountability.
Thank you so much. And I'm happy that we acknowledge sometimes we have speed bumps on our roads to our career successes, and it doesn't mean that it's a bad thing. You have gifts to give the world, and I definitely see you as running health systems. So props to you. Queena?
Hi, everybody. My name is Queena Sabri Williams. I'm a current PA student at the University of Eastern Shore. I'll be graduating in December of this year, so I'm pretty excited for that. So my journey / pathway into healthcare was just a bit nuanced. So growing up, I'm also a first generation Ghanaian American. So it was a lot of struggles when it came into going into healthcare, like trying to help out my mom with understanding like paperwork and everything. And also my late father had leukemia. So dealing with that and also having to commute from Prince George's County to DC and just always seeing and being surrounded with healthcare providers and other healthcare professionals because of his cancer journey. I didn't know at the time where I would end up going, but I knew that I wanted to step into the same atmosphere and also provide back to my community in the same ways that people had served my father and also had supported my mother. So during my undergraduate year, I had discovered the PA profession, and it was just something that spoke to me, that called out to me, and I was just very excited to go for that journey. And I made it a mission to go to the University of Maryland Eastern Shore because it was an HBCU and also one of the few HBCUs that has PA programs. And I feel very supported and just very loved in that atmosphere and always feel pushed to be the best I can be. And I would say one thing that truly gives me hope is learning communities such as this and the Social Mission Alliance. Like I still have a really great time being a health justice fellow. I've learned so much, especially about health disparities and also being an advocate for healthcare outcomes. And also, one of the things that I do have fear about is just funding, especially for universities such as my own, where there's not enough funding for our program, or we struggle to give scholarships to students. And also, with the big, beautiful bill classifying the PA profession as not being professional. So, just worrying how students coming after me will be able to support themselves throughout these programs.
Thank you so much. Okay, so the next question is also kind of two together. We talk a lot about the pathway or pipeline, but where is it actually breaking down for Black students and future healthcare professionals? And for students navigating this journey in terms of pursuing their health careers, what are critical skills or experiences that might not be curriculum that you think are super important?
Yay.
Let's pause. My apologies. Want to introduce you?
Yes, and don't worry, these things happen. I wasn't called, so I said there must have been a change. I'm not going to go up there if I'm not called. I'm on the panel. My name is Dr. Janet Franklin. I'm at Amgen. I mentioned before my question earlier that I was in academic medicine before, pediatric hemonc, and certainly have had a lot of experience and passion around the area of the next generation coming through in terms of healthcare industries, professions, and also the importance of access, mentoring, sponsorship, all those things.
So I want to give you an opportunity to answer the first question in terms of what gives you hope in your career up until this point, and what concerns you have relative to the future of health professions training and workforce.
I'm a glass half full person in general, just to put that out there. And so my optimism comes about just from the opportunities where I've had a chance to mentor or to meet with student groups and things of those natures, where I see people who are either beginning their medical school career or have decided they want to go into other healthcare professions. And they have a spark where they say, I didn't know, I've not met a lot of people like you, and now I know I can do this. So that's part of why I have optimism. I think if role models still play a big role in our world, and we can't really underscore that we have to underscore that more and more, because that's really a lot of dynamics that are probably working against people feeling they can do certain things. And so I think that still has a place for everyone. And so I do believe in that whole thing in terms of, giving back and paying it forward. Those things really have value for our entire communities, particularly when we think about young students who are very impressionable and have lots of things that distract them. So.
Great points, great points. So let's go back to the question that I asked before in terms of where do you think people, particularly Black students and students who are underrepresented in medicine, are falling off the pathway, or being pushed out of the pathway? And what are the skills that we don't historically teach in health professional training programs or undergrad that are crucial for their future development as leaders to change the system? I'd like to go first.
Hello. So I would say from my experience, it would be from the beginning. When I was applying for PA school, I had a lot of trouble finding mentorship and connecting, and also finding people like me that were within the field. And so that came with figuring out financial aid, application support, as well as even making my personal statement. And so I really did not know what to do. I had to ask a lot of questions, and I felt as though I didn't know who I could go to. And that's a common theme that I've noticed with people or students that are interested in going into the field. It kind of also propelled me and pushed me with SMA to help make a pre-PA pathway program so that I can support other students, especially in the state of Maryland, that want to go into the PA field but don't have the support, and they can find the support through that program and also find that mentorship.
I agree. I think, again, with students like me, when I was coming in, schools like Emory do have the resources there for sure in terms of like pre-health advising. But I think students come in with a limited understanding of what the healthcare field actually has to offer. I think everyone either thinks you can be a doctor or a nurse or anything really with clinical or a clinical setting, and that's it. So a lot of the students that were like me, that after Orgo, they said that's enough. They just completely said bye to healthcare and tried to pursue something else. But they didn't know that there were other opportunities in the healthcare field, because we don't have a lot of mentors like that look like us in those fields, but also there isn't enough representation on our campuses as well. And we're not taught about those things in an academic setting or even just an internship setting either. So I think the most important thing is for us to seek out those opportunities to connect with people that are in those other spaces. And it's also important on the other side that those people let us know that they're there too. Because again, any type of relationship, any mentorship is two-sided. So I think that's really important for us to understand.
Completely agree. Caitlin?
I would definitely second that and add some more specifics. I think that first year of college, a lot of students, I think we've done really good at trying to support our kids, our older adolescents into getting into college, but I don't think they get enough support when they get there that first year. That transition is a really large transition. I think a lot of pipelines kind of skip over that and focus on the later years towards the application process. And a lot of times what I feel like I've seen is that's almost too late for them to get that additional help that they need. In terms of skills that I think should be stressed a little bit more for our medical education as a whole, I think just being a human being and remembering that you're treating human beings, it becomes kind of like a competition of numbers at some point, and it's really important that we kind of remind them at every stage that the most important person in the room is the patient and not them.
Thank you.
I think my concern is coming around the idea of funding, because I think of a lot of the programs that I used to get invited to. There was like Saturday Science Symposium that was for elementary school children and junior high school children. They would come up, have a day just devoted to meeting people who are scientists, who are in the lab, who are radiation technologists, just all kinds of areas to give them exposure about what you could be. And they also had a whole day of programs that was, designed to be hands-on, quite a wide age range. And I remember how much I enjoyed that. And I also think about the programs where, when I was coming along, there were a lot of summer opportunities for pre-med programs or programs for persons interested in a science career. And you could apply. And again, these were definitely focused for minority students, primarily Black students, but minority students. And there are less and less of those now. And I worry about that because those are the avenues that I remember myself and some of my friends who also were successful in going to medicine. That's how we got kind of nourished and had exposure, understood more about what it was that we could do and how you could actually do it. And the funding issues are real. And that's been a real problem, I think.
I agree entirely. And I think you mentioned the importance of like networking, understanding the different roles that make up the healthcare team and how invaluable each one is. And I think Dr. Franklin, you make a good point that support systems for mentorship, for sponsorship are being defunded, are drying up. People who historically mentor people are running out of places to recommend that students take part of. And so that leads to the next question around mentorship and sponsorship individually and on the part of institutions. In this, brave new world that we've entered, where certain words and certain programs are either forced underground or erased entirely, how do we move from mentorship to sponsorship for a generation of people who need this as much as ever?
I'm happy to start with that. I mean, I think sponsorship really is easiest, though it needs to be done in many areas, when there's an organization structure to it, in the sense that I think my current job right now. So if I look for persons I want to sponsor, I'm going to look around me. And so, and I have an affinity for those who look like me, no question. But certainly sometimes others have also reached out. So I think that's one way to be a sponsor, because you know your pathway, what the ups and downs were along your way, because it's never smooth. And then you have a really clear vision as to how you might be able to sponsor someone else to be able to take their own skills, their own profile, their own CV, strengths, and move along, step by step. It's not a big leap, but it's by steps, right? I think the other way is that I've had just relatives or friends refer me to their neighbors' daughters, whatever, boyfriend, and he's interested in, pre-med, or he's interested in science, or he might want to go into pharmaceutical industry, or whatever it might be, whatever the linker is. And they give them they say, can he call you? Can he email you? And I always say yes. And that's been one way I've been able to try to be a mentor / sponsor for someone in that setting too. But again, it takes someone, helping them out to make a connection. I know it's hard when you're much younger to maybe always feel like you can reach out to someone who's so-called, older than you or more established in their career than you.
Thank you for that.
I think in terms of sponsorship, my biggest, as kind of the in-between with resident, not a student, but also not a full-fledged tending, is making the connection with people. So while I may not be the most senior person in the room, I'm not the chair of your department. I am someone who works with the chair of the department. I am someone who works with these people. So leveraging those personal relationships on behalf of others, I feel like is something I'm really big on right now. In terms of mentorship, just guiding people and asking any question they would like. I generally, for the medical students that come through the emergency department, always like to let them know, like, yes, I'm an ER doctor, but I had other doctor friends or other specialty friends that I would love to help you connect with. And I think that that's another part of mentorship, is just, if you can't directly provide the thing that they need, finding the person for them.
Yeah, definitely piggyback on that. That's a really big thing. I think when it comes to sponsorship, again, like I said in my last response, it's a two-sided relationship. So not only does the person seeking advice need to reach out, but the person who's supposed to provide it say, hey, let me contact this dude and let me contact this person, let me get you whatever, because that's the role of a sponsor and that's the role of a mentor. So it really takes being intentional about your actions and intentional about what you want the relationship to be like for that to prosper.
I agree with what everyone else had said, because it really does resonate. Just having a strong network and a strong support, and also having it be two-sided. I just say, like, from my own experience from the Social Mission Alliance, like, helping me take my words into an actionable step was really something that really changed and let me know, like, okay, I'm getting the support, I'm getting the sponsorship, and I'm ready to just take my ideas and really take the next step and connect with others, so I can also be a support in the future.
Thank you. I think you, like many of you, alluded to individual relationships, but relationships within systems. And I think the systems that we exist in, whether health systems, academic institutions, private organizations, all have a role to play in facilitating these communities, these networks, these mentoring relationships, these sponsorship opportunities. And right now, do you have any recommendations or like requests in terms of how you think institutions like the ones that I've named should step up to support the pathway and the relationships that will sustain people along the pathway and lead them down the go off?
Funding, 100%. Write a check, run a fundraiser, any of these things. I think right now, especially in our unprecedented times, I know we're tired of hearing that, we have to get more creative than ever to kind of support those students that fall through the gaps. I've seen some very interesting linguistics jujitsu at even our own institution to make sure that funding is still present and there for those students. So I'd say that is the biggest thing an institution can do, is continue to stick by those goals, even if you're changing the name of the program or changing the name of some of the mission, changing a couple of words of the mission statement. I think the overall goal stays the same. And if you really care about something, you put your money where your mouth is.
I 100% agree with that as well. I think funding is also important. And another thing that I would say is really organizing with students as well, because sometimes I would see, just from my own experiences, like the institution would talk about things and try and organize it, but students aren't really involved. So there isn't much of a connect with what would support the students or what students are interested in. So things tend to fall off more early than they could.
Yeah, I would definitely say, like, listening to the people that are asking, and like, you have to be intentional about what you're going to do. So as an institution, whether it's academic or even if it's a community center, like, being intentional about what your goals are for those students and listening to the students to make sure that you're meeting them. I think that's the most important thing. Don't try to make up something that you think they're going to like. Listen to what they're asking for. Yeah.
I think one of the things that companies can do, or larger institutions of any type, is to sponsor summer programs, summer internships. I know at Amgen we have a summer intern program that's pretty diverse. You have to work hard to make it diverse, because otherwise it gets really easy to not do that. But I think that's really important, and I know that you're spending that time in that environment is just really enriching, no matter what you decide to do later. Doesn't matter whether you change your mind or not. And I think that it can, I think other, colleges and universities have summer programs as well. But I think, again, it's kind of maybe harder to do or less easy to fund, or you need the volunteer staff or faculty, whoever you're drawing on for your resources to make the program work, because these things tend to be from that mechanism, not from someone who's full time. And I think that's the way to try to keep that in mind. Those things have value, and again, you're right. Sometimes the labels or the names have to be changed, but I think it's important just to have that's to me like community outreach. To me, that's one way of doing community outreach.
Could you speak more to the intentionality required to keep things diverse, to do the outreach that could make that kind of happen?
Intentionality is probably everything. And I know that we have an academics group that has been really keen in terms of, developing and broadening the schools that we reach out to, no matter what, area of say, a business such as a biotech company might be recruiting for. And so while we go to some of the most classic universities you would think of, I think we've had over the last several years stronger connections with many HBCUs and other public universities where they have, really sizable numbers of minority students. So again, the presence is everything, because, people don't know about Amgen necessarily. It's not something a company you would know about if you were just an undergrad or a high school student. And I think the other thing is that by coming to those places, you can be asked the questions that students want to know, so they can figure out, well, is this for me, or is this another pathway I want to join that's slightly different, but at least I know what that is and that's not me. So those things are important. We've also gone to some of the student conferences, Black engineers, for example, and chemists and things like that as well, to have a presence. And so again, you have to make yourself available to the audience that may want to reach out to you. And so that's another thing we've been trying to do in our setting.
Those are really great points, and definitely something that I try to emulate with the programs that I lead. So we're wrapping up with the final question for everyone. And the question is, it's an actionable question. What recommendations would you make for a student on the pathway to actions that they can proactively take right now to increase their likelihood of succeeding, finding mentors, finding the resources that are crucial to support?
I would probably, sorry, that's the emergency medicine in me. I'm just like, let's just talk about it. I would probably say, don't be afraid, send the email. Working with middle schoolers, you would be surprised how uncomfortable most of them are, or not, if you're a pediatrician, how uncomfortable they are talking to strangers or people who necessarily they don't have a great relationship or they haven't grown up with. So really encouraging, no matter where you are in that pipeline, I promise you, if the worst thing that could possibly happen is they don't email you back. And that's it. But the best thing that could happen is you could make a mentor for life. One of the best people I have met and is still my mentor to this day is someone who I emailed as a medical student. As a third-year medical student, she is my attending now. She helps me with my research. She helped me apply for chief. So that cold email means a whole lot.
Yeah, I would say cold email everyone. Take advantage of those coffee chats. Talk to your professors. Talk to your professors, because most of them have PhDs or did something outside of academia. That's how I got one of my internships. Just use your networks and take advantage of every opportunity that's presented to you. Even if you don't think you're going to be interested in it for your career, just do it anyway, because you never know who you're going to meet.
I agree. I was just thinking to myself, the worst opportunity is missed opportunities. So the best thing you can do for yourself is put yourself out there, even in the face of doubt. Because there's been so many times, and I believe a lot of people can relate, where I would think maybe it might not work out, but then I'm just like, it will. And then sometimes it does, sometimes it doesn't. So I think just having confidence in yourself will take you far.
Thinking a little bit differently on this question, I think one of the things that I would say is actionable for everyone in the room is that you yourself can be an advocate or a sponsor or a mentor for someone, even if it's just a connecting factor. So I'm thinking about how you'll hear someone say, for example, your friend comes over with their children, they talk about, well, I want to be a scientist, I want to be a ballet dancer, and someone says, well, I want to be a doctor, or that's my example, I can give you, a nurse or whatever it could be. And you certainly need to pick up on those things, because if they really have that interest, you have to figure ways, how can I foster it? What do I know? what's in my community where I could get them maybe to join the science club for kids or this high school, college bound group or whatever it might be. I mean, sometimes we have to help those who don't know those resources. So I think it's not always about what they can do. You're adult, you can do that, but I'm thinking about those who are still the early pipelines. What I worry about losing, and therefore, if you can't get them to a certain age where they really have the ability to make decisions and discern what's probably for them, then it's how do we make sure we don't lose those opportunities to let them know that there's ways to get more information about that, or you can find out a fun way to see if this is something you like to do, and let them encourage it. Just encourage it, the way we do for those who say they want to do music lessons and other kinds of things.
Thank you so much. And it's a two-way street, like y'all said, and thank you for emphasizing what can happen on the other side. So that's the last question for the panel, but I think there's a lot of wisdom in this room as well. And so I want to use the time for questions, but also suggestions from the role of mentee, mentor, sponsor. What can we all be doing to advance the pathway as the ground moves under our feet?
Good afternoon, everyone. As the educator in the room, we are facing the demographic cliff. So we are not seeing as many students that are applying to higher ed and into these different professions. But not everyone knows what all of the healthcare professions are. So a lot of people think that I can only be a doctor or I can only be a nurse. So they do not know about all of the others. So we need to get out there and tell them about these pathways into healthcare. The other thing too is we have advisors, mentors, and sponsors. And most students are looking for sponsors with the money. And the advisors at the different school levels do not also know about the different pathways. So we have to start getting in there and start speaking, what the truth is about healthcare. My fear as an educator is not seeing people that look like me and not seeing women getting into these fields and into these professions because they do not know. So we have to tell them. So that's my call to action for everyone in the room. Help me help you be the best that you can be, and help me help our future be the best that they can be in these times, because this too shall pass.
I want to be fair on either side of the room, so we'll go. If you don't have a mic over here, we can go.
I can talk a lot. So I represent a group of physicians called the Association of Nigerian Physicians in the Americas. And for those of you who know Nigerians, we're loud and we get a lot of degrees. There's a lot of us who are doctors, and every year there's a conference. It rotates. It's going to be in Chicago. And we have this special program where we try to give back to communities of color in the Americas, because you guys are hosting us and we're thriving. So if you don't know about AMPA.org, there's an entire effort partnering with Mentoring in Medicine to kind of bring young minorities to learn about the health sciences and medicine and pharmacy and nursing. And we really would love to connect with BDO. I think I put a note to follow up later to see how we can support this work that you guys are talking about here. I mentor a lot of people around the world in medicine and science. It's a passion that we have. And so please, let's connect with BDO and figure out how to bring the two groups together. Okay, thank you.
Yes, we must absolutely put a pin in that in terms of professional societies, state chapters, et cetera, really coming together to make the road. I think we have time for more questions.
Hi again. So first, amazing panel. Thank you everyone for your insight and expertise. Go GWEmed. So I think one thing we have to also focus on is teaching mentees how to be good mentees. And sometimes that's some of the hardest things to do. Those are some of the most difficult conversations. The path of least resistance is to let someone mess up and just let them go about their business and keep failing. And I think that while it's a tough conversation, we need to be comfortable and also meet the mentee in a way that doesn't necessarily put them on guard or on the defensive and not willing to listen. And that could be as simple as saying, you probably shouldn't have put that in an email, or, it probably wasn't great that you were on Pokemon Go in the middle of clinic. That actually happened. Not kidding. There are better ways to spend one's time, but I think it's easier to not to just ignore the problem. And it's our job as mentors, let alone sponsors, to set people up for success. So it's something as simple as saying and I'm sure many have gotten this in the room, the email of, hey, do you have a project for me? Thanks. It's like one line. And it's not thinking about, well, what kind of work do you do? Sometimes it's even about a project that you don't even work in. So I tell students, I'm like, hey, listen, I don't have a magical pot of projects, but if you have an idea and a question, I'll help you work through it. It's about being intentional in those emails, but intentional about meetings. I mean, someone mentioned about meeting at conferences, which is a great place to meet with a lot of mentors. Do not email the last days beforehand. It's months before with a purpose. And so I think as mentors, we can really set our people for success with very simple changes, let alone we need to be willing to have those tough conversations that things they have done may not have been the best for the environment, for their careers. And even though it might be hard in the moment, they will thank you down the road.
Yeah. Hi. You're probably thinking she has a question. No, more like a statement. And yeah, we're just going to go there because you guys are Social Mission Alliance. So how do you feel about, let's just call it out. There is an attack on higher ed. There's an attack on DEI. And you know the stats. People like us with an EDD, PhD, Black folks, we're 2%. Black doctors, 6%. We can go on and on and on. So how can we actually work together, BlackDoctor and all of our other industry partners, to ensure our future for representation, because it matters?
Anyone want to answer? So while he gets, okay, let's get Dr. Straight.
Well, it's not a total answer, but it is something that I think we have to pay attention to. The history, particularly of Black people in the United States, is we've always taken care of our community. So we've never had money to start with, and we've always utilized some form of support within our communities. And in today's environment, there are actually institutions where faculty have been told that they can't write a recommendation for a student for a scholarship that's specific to Black students because of this new anti-DEI thing. And it's a place where in some campuses where students are not even able to have affinity group. We have to utilize our own communities. We have to utilize, if there's a sorority or a fraternity and they have a house, we have to get them to be able to sponsor places where we can all meet together. They don't have to necessarily pay us for it, but if we can have environments like that, we have to start using and building our own institutions like BlackDoctor. But I think it's going to take more than that. And that's going to be something that we're going to have to really, really get together and do, because the institutions are even being told not to refer people to those. So we have to use our own networking in this process. And that's just one other thing I just want to bring up. So, if it's your church, if it's your sorority, fraternity, if it's your brother got a store down the street, whatever it is, we have to do that.
I just want to add quickly, yeah, definitely pouring into organizations that are for us, but I will say some of my best mentors were people that didn't look like me. So it's really important to, when we think about diversity, not just think about, oh, I want a Black mentor, but get a mentor who's white or a different race or a different gender, because they have connections too and networks too that you might not know exist, right? So don't be so one-dimensional, be open to really, truly diversity.
I would like to add to that and also use those individuals as, for lack of better words, a shield. There are some things that coming from someone that looks like the same as the person you're trying to advocate for can come off aggressive or seeing as being favoritism, etc. So using those other mentors that may not look like you is a wonderful way. Like I've written emails and been like, you send this, and it works phenomenally.
Okay, So thank you all so much. We have a lot to learn, and I think there are a lot of actionable items within this room. And keeping with that theme, don't mean to steal it from our wonderful hosts. Thank you so much to our panelists.
Yes, another awesome panel. You all made it. Made it. Yes. Before we close out today, I have a couple of special messages. This first special message comes in from an NBA champion, a 7-time NBA All-Star, a 2-time NBA Defensive Player of the Year, another 2-time All-Defensive First Team. He is a friend of BlackDoctor. Please look at the big screens for Mr. Alonzo Mourning.
Hi, I'm Alonzo Mourning. Many people know me for my basketball career, but today I'm also proud to stand here as a kidney health advocate. My own health journey changed my life. It's what drives me to use my platform to raise awareness of APOL1 mediated kidney disease, which disproportionately affects Black communities. I want to congratulate each and every one of you for being recognized as top Blacks in healthcare. This honor reflects more than professional success. It reflects your dedication to advancing our communities. The work you do every day matters. You open up doors, you build trust, and you're shaping a healthier future for the next generation. Whether you're caring for patients, advancing research, shaping policy, or educating the next generation, you're helping improve health outcomes. And you're making sure our communities are seen, heard, and supported. That kind of resilience, people showing up and pushing forward, is what carried me through my journey, and it still does today. So thank you for your leadership and your commitment to moving us all forward. Congratulations again on this well-deserved recognition. God bless.
Right, Mr. Alonzo Mourning. Okay, today we've heard a lot. We've learned a lot. A few of us, including me, have shed a couple tears today. We've grown closer today. So what do we do next? Well, we came up with something that I believe will bring us all together and point us in the next direction. So we created something that we like to call the BlackDoctor Pledge. If I could have everyone stand up. The BlackDoctor Pledge, to sum it up, it sums up what everybody was talking about today. We want to see change. We want to see the needle moving. We want to have impact in our communities, in our families, in our homes, with the folks that we love and who are near and dear to our heart. So you can sign up to this pledge using this QR code. If your Wi-Fi isn't working in this room, because you know sometimes Wi-Fi be coming in and out, we'll definitely, once you move out of the room, then you can sign up that way. But let me say it, then you repeat it. We'll do sort of call and response, just like church. Amen. I wanted to say, turn to your neighbor. No, I just want to. Let me not get started. Right. Okay. All right. I commit. Oh, I'm sorry. That's the part where y'all repeat. Sorry. I commit to advancing health equity in the communities I serve. I will use my voice, expertise, and platform to improve health outcomes for Black communities. I will support culturally relevant education, advocacy, and access to care. I will collaborate with BlackDoctor. You see how we put ourselves in there? You see that? Mm-hmm. To amplify trusted information and drive meaningful change. And I will take action beyond today to help power the future of our health. And that is the BlackDoctor Pledge. All right? So to close us out, before we do that, I've got one last special message, and that special message is to our sponsors today. We've got to give it up for Novo Nordisk, UCB, Amgen, Novartis, Bayer, Vertex, and our partner Social Mission Alliance and Limitless Impact Foundation. Thank you. You all made this day possible. So please continue to stand, or as they say in church, rest on your feet for our new CEO. And he brings a new cool factor to BlackDoctor, Mr. Aki Garrett.
I don't know if this is much of a close. I think that was the close, right? I mean, you just kind of brought it all together, tied a nice bow on top. But no, I want to sincerely thank everybody, one, for coming today. I want to thank our sponsors, our partners, our KOLs, our thought leaders, and just everyone in this room that is so passionate about a mission that I'm very passionate about. I often get the question, like, why did I leave the sexy world of, media and celebrities and hanging out with, basketball players and entertainers, actors, musicians, many of whom you all know, right? And, being more on the, I guess, the flashier side of media to come to BlackDoctor. And what I said was, before this, it wasn't about the title, it wasn't about the business opportunity, it was really a calling. And it was a calling for me from personal experience. About 10 years ago, I lost my brother suddenly to cardiac arrest. He was 46 years old. He had what they call hypertrophic cardiomyopathy, which is the enlargement of the heart led to an arrhythmia, and it was undiagnosed. He had no clue. He looked as healthy as he could be, ate healthy, went to the gym one day and never made it back home. And he had an 8-month-old daughter who is now 11 years old, and she never got to know her father. And so, she's gotten to know him through, luckily he was one of 7 siblings, so there's a lot of us. And so we're able to kind of tell her about her father. And that really just cemented my passion for, I mean, I've always been to wellness and health. I've always tried to stay fit, work out, and be conscious of my numbers, be conscious of what I put in my body. I regularly get checked up and so forth. But that really was the kind of eureka awakening moment where I was like, this is real, right? And this is a matter of life and death, literally. And so when I got the call from the recruiter, or the LinkedIn message from the recruiter, I saw it as a divine alignment. I saw it as me stepping into this season of my life and really aligning my passion and my mission for, what I call the civil rights movement of the 21st century, which is health equity, right? Every human being should be entitled to health, access to healthcare, and access to and the ability to afford to take care of not only themselves but their family. And so it's days like this that are just reminders that what we do is so important. And what's so encouraging is that I know that it's not just me, it's not just BlackDoctor. There's an army of people, each one of you in this room, who understand the mission. And so as we depart this part of the Top Blacks in Health celebration, we obviously got the gala tonight. We're going to turn up. I leave inspired, and I leave, just continually hopeful for what the future could look like. And so thank you all for your commitment, and we'll see many of you later this evening. Enjoy the rest of your day. Take care.